Welcome to the Daily Apple. I'm your host, Kevin White. Emma Ryan and I will dive into all topics related to the science of longevity, along with some other subjects we just find of interest, with the hopes to provide useful information for everyone. This stems from my personal interest to optimize the human condition, to not just live longer, but to live better. Hey, Dr. Scott and everybody, welcome back to the Daily Apple, and thanks for making time today. And I'm really kind of thrilled and giddy and excited that I get to talk to the good Dr. Tara Scott, and she's here with us today from Ohio, and she is often known as the Hormone Guru. She's board certified in OB-GYN with over 25 years experience.
It's probably close to 30 now.
Yeah, I was thinking. And really a leading expert in this space. Also certified as a menopause practitioner by the North American Menopause Society, which is a big deal in this space. It means you really know what you're talking about. And the founder of Revitalized Medical Group, and just a renowned educator and speaker, lectured internationally, got a TEDx talk out there, which I recommend people looking up, and really dedicated your career to helping women navigate the complex journey of hormonal health from perimenopause to postmenopause, and really using evidence-based approaches. So I'd heard you speak first time about maybe on the main stage, I think about 4 years ago, 5 years ago, I don't remember. And then multiple times. And the reason I wanted to reach out to you is because I've even had patients come to me with some preconceived things from other caregivers that have kind of been outdated, and concerns for cancer and, you know, all kinds of things, which we'll get into. But I thought, man, aren't we past this? And it seems like we're not. And it's kind of the same thing over and over again. But I thought I've got to get somebody who is really a leader in this space and well respected. And your name has been on my mind for a long time. And I finally reached out to you, and I appreciate you making the time today. So thank you very much.
Well, thanks for having me.
Yeah. Well, I want to start off with, I mean, everyone's kind of got this story of how they kind of veered off and got into this space. And I mean, you were originally traditionally trained, you know, as I was too, in, you know, different areas. But what was it that flipped the switch for you? What is it, your story, that kind of brought you, you know, changed your trajectory, so to speak?
Well, there were a couple things. So as you mentioned, I was a traditionally trained OB-GYN, and I really loved delivering babies and taking care of women at all stages. And it was at the time where malpractice insurance was really, really expensive and unaffordable. And I had 3 little kids at home. So I took like a year to just do GYN. And then I was really just seeing all of my patients. That was right around the time that the WHI came out, so the pendulum was swinging to people to not take hormones. And I personally had my own little hormone journey with infertility. And so I'd always been interested in hormones. So I took that time to start learning about hormone therapy, bioidentical hormone therapy, testing hormones. And then a couple of years later, my brother suddenly passed away at the age of 38. So he had a heart attack and he was hiking. And so, you know, he had every risk factor. He was a smoker. He was on a statin. He had high cholesterol. He was insulin-dependent diabetic. So it felt like that was a totally preventable death. And so at that point, I really kind of dove headfirst into integrative and functional medicine, you know, focusing on women and hormones, but also with a preventative approach. I mean, we do a lot of metabolic health because it's directly tied to hormone therapy and hormone balance in women, but, you know, trying to prevent diabetes and trying to prevent heart disease, as it is the number one killer in women. So that's kind of how I ended up where I am now. And that was, you know, that was before, I'm a dinosaur, right? It's before it was. Now, thankfully, we have so many more studies. We have so many more resources. We didn't have that. This was like 2003 when I started kind of shifting my practice. 22 years ago, 21 years ago.
Yeah. Yeah. So you shifted in 2003. That's a long time ago.
Yeah.
Yeah. Okay. Well, so you were so whenever you did that, did your colleagues kind of think, hey, what are you doing?
Yes, they did. And so I, you know, trained in the town that I work in. So I was pretty well known. I was a great resident. I had a good reputation. I joined the busiest OB-GYN practice, you know. And so when I had that time that I just did GYN, I was kind of in just a 2 practice. And then I ended up joining a couple of years later, a large single specialty practice of 16 OB-GYNs, because I decided to go back to delivering babies, and I needed the call support And they had me kind of at these morning meetings, these monthly morning meetings. Oh, we're going to have you talk about, and they would fire questions at me, like just really like kind of like eye rolling. And
Yeah.
I would just answer back with the physiology, with the evidence. And like I said, this was circa 2006, 2007. So some of the studies that I always quote are like after that.
Hmm.
And after like 2 or 3 rounds of that they were had me on the chopping block and the grilling, they're like, "Okay, whatever. We don't understand it, but she seems to have a reason for what she does." And so
Yeah.
now it's come full circle that when I kind of left that practice and did just the hormones, other OB-GYNs would refer to me because they wouldn't refer to me to another OB-GYN practice because then they thought that practice would, that patient would come to our practice and to have their baby and have whatever
Mm.
surgery with our practice instead of theirs. So I was seen as a competitor. But once I stopped doing OB-GYN, then the rest of the people in the town, then would refer to me. So it's kind of an interesting thing how I was very criticized. And I remember they're like, why, hearing them say, why is she doing that? Why would she do that?
Yeah.
Because there was somebody who was kind of doing it, dabbling in like hormone therapy, but she wasn't very scientific about it. I mean,
Hmm.
she really was trying to do it for the patients, but she just really wasn't very scientific about it. She was more woo woo,
Hmm.
so
Hmm.
it's good when things come full circle.
Yeah. Yeah. Well, yeah, today, the reason I want to get into this again was, there's been some misconceptions and things, and I just kind of want to really go over stuff. There's still some fear and everything. So I want to go over some things like why women should consider hormone therapy, who should consider hormone therapy, when should you start, delving in on that kind of stuff, and some common, myths and everything, and why there doesn't need to be a lot of fear with that, and who should be, concerned, and the ways we can mitigate those things. But I guess we should start off with, why in the perimenopausal period should women consider hormonal therapy and support?
Well, let's talk. I give my 5-minute speech to my patients when they come in,
Yeah.
about the risks and benefits. So it seems
Yeah.
like this is a good place for that. So, if you look at the FDA reasons that they are indicated to take hormone therapy,
Hmm.
it's vasomotor symptoms,
Hmm.
which is hot flashes, night sweats. It's something called genitourinary syndrome of menopause, which would be vaginal dryness, painful intercourse, frequent UTIs, getting up at the bathroom in the middle of the night to go to the bathroom, any vaginal symptoms, number 2. Number 3, prevention of bone osteoporosis, which applies to all women. And number 4 would be if you have premature menopause, which would be menopause before the age of 45. So
Hmm.
that was what the FDA said. The makers of Prempro, Premarin and Provera did sponsored the Women's Health Initiative, which is where kind of all things went south. If you look at things in the Prempro was the most prescribed medication in the United States. And so we know that the number 1 killer in women is heart disease. Number 2 is stroke. Number 3 is lung cancer. Number 4 is breast cancer. And if you add up the number of deaths from 2, 3, and 4, you still don't equal the number of deaths from heart disease. So they were seeing that women who took hormone therapy, namely Premarin, were having an improvement in their heart disease, and there was less heart disease. And while it's tragic, like my brother dying of a heart attack at 38, you don't ever hear of women, rarely of
Right.
women at that age before menopause having a heart attack, right? You do hear of men, unfortunately, but like I said, it's just, there's a protective effect of estrogen for heart disease for women. So the makers of Prempro set out to do a study because they wanted a 5th indication from the FDA for primary prevention of heart disease. They weren't doing that study to see if it was safe. It had long been proven safe. This was in the 90s. I mean, this had been prescribed medications since the 60s.
Hmm.
And they started giving estrogen only because they couldn't figure out how to make progesterone. And then they ended up putting a synthetic version that was similar to a birth control pill because they didn't have the technology to make micronized progesterone. And when they gave estrogen only, they saw an increased risk of uterine cancer.
Hmm.
So there was no concerns with the safety of this medication. They did the study to see if they could get a 5th indication from the FDA for primary prevention of heart disease. So that means every woman could take hormones to prevent heart disease because it's the number 1 killer. What do you think that meant for the drug company? Everyone's going to
Hmm.
take their medication now. So
Hmm.
to do this, they needed a randomized placebo-controlled trial. So they started out and they had 8,000 people that took the drug, 8,000 people that took the placebo. And they had a second arm of women who had no uterus who took estrogen only.
Right.
And after about 5 years, they saw there was an increased risk of blood clots and there was an increased risk of breast cancer. And those findings were on Good Morning America before it even made it into our scientific journal. And I
Hmm.
remember I was in practice, we were flooded with phone calls that day.
Yeah.
So what does that really mean? So I think it's like 8 out of 10,000 more blood clots or clots in your lungs, which can be fatal. So it's concerning. But after that, there was a couple studies done in 2008. There was one in the British Medical Journal that was a meta-analysis by Marianne Canonico. So she looked at 17 different studies. And what she found is that oral estrogen, when you take it, it goes through the liver. That's where the blood clotting proteins are.
Hmm.
And those versions of estrogen that were given orally had an increased risk of blood clots. But the versions of estradiol that were given transdermally in a gel or a patch had no increased risk of blood clot. I mean, anyone's at risk for blood clot at any time. So there's no increased risk. So the first thing we never do is give oral estrogen. So
Right.
the second question is what is the risk of breast cancer? The Menopause Society says that for women between the ages of 50 and 60 in their latest position statement in 2022, you have more benefits than risk than taking hormone therapy. And they quote the risk of breast cancer, additional risk as 1 out of 1,000. So as a woman,
Right.
your risk of breast cancer is 1 in 8, which is 13%. If you choose to take bioidentical hormones like an estradiol patch and micronized progesterone, you will incur an additional 0.01%. And if you take Prempro, which is a synthetic estrogen, a
Hmm.
synthetic progestin, you will have an increased risk of 3 out of 1,000, so 0.03%. So your risk goes from 13% to 13.01.
Hmm.
So it's really not a huge increased risk of breast cancer. So that's what they're saying is it's pretty negligible, but you can't say there's no risk. And
Right.
so there was another large study that was done in Europe. It was an observational study. So it wasn't a randomized placebo-controlled trial, but they had 80,000 people, so 5 times more women than in the WHI. These women
Gotcha.
were 40 to 64,
Uh,
which is a more appropriate age range because we know the risk is higher the older you get. And so they had a control group who took no hormones. They had a group that took estrogen. Most of the people in this group, 97% were using transdermal estrogen. So it kind of takes out the variable of oral estrogen and conjugated equine estrogens. In this group is mostly transdermal estradiol. And what they found is that women who took transdermal estradiol and micronized progesterone had no increased risk of breast cancer. And they followed these women for 8 years when they compared it to the control group.
hmm.
So these are the studies that I share with my patients, those 3 studies and the menopause position statement. And then, the patients get to make their own decision. According to the position statement, there's also observational studies been a 19% decrease in diabetes in women who take HRT. There have been cognitive changes that are associated with menopause, and there are observational studies that show that it decreases dementia. One had, gosh, I can't remember. It was like 400,000 women. It's the Women's Alzheimer's Translational Research Board. It was an observational study,
Hmm.
and they had up to a 58% decrease in Alzheimer's. And those were women who were 65 taking hormone therapy for 5 years or more. So,
How long did
there's
they follow those women with that dementia study? Do you
I
recall?
mean, that was 5 years. They were
Okay.
seeing a difference, and there was an increase in reduction rate in the women who took the bioidentical forms.
Hmm.
And so those were older women, 65, for at least 5 to 6 years of HRT.
Hmm.
And so that was published a couple of years ago. I'm guessing 2022, but I don't have that resource right here.
Hmm.
So there are, but when when you look at data, we're touting the randomized placebo-controlled trials as the highest form of evidence. But for a woman who has endogenous hormones, and then we all obviously have different ways of metabolizing estrogen, I find it very hard to randomize a trial. I mean, they don't do baseline hormone labs because
Hmm.
that's not even to the standard of care to check hormone labs.
Hmm.
So how do they randomize those patients? So I think observational trials, if they're well constructed and they have a control group and they have, a large number, are also very valid data.
Yeah, sorry, my mind's going a lot of different places. I've got so many questions I need to ask you. But when you go back, the Women's Health Initiative, I've really dug into that over the past week. I mean, I know about it from reading and hearing people talk about it and all that. But the interesting thing, and you said that there, is in that study where they did conjugated equine estrogen from horse urine and, synthetic progesterone, which is not, the same chemical structure of your God-given progesterone, even then it was 1 in 1,000 of,
It was like 3 in 1,000 is what the Menopause Society says in their position statement. So yeah, it was very low.
yeah.
And so, and you make an important distinction. There's several follow-up studies that do compare head to head
Hmm.
medroxyprogesterone acetate or Provera and micronized progesterone. We may hear of it as Prometrium.
Yeah.
And so they're thinking that the risk of breast cancer was the synthetic progestin.
Hmm.
We have similar studies looking at oral contraceptives
Hmm.
showing that there's an increased risk of breast cancer. Small increased risk, but there is the longer you're on oral contraceptives, and those are synthetic progestins also. So hopefully people are now trending more towards not using progestins for hormone replacement therapy. We use them for birth control because
Hmm.
that's a different process. It's a different goal. But when we're trying to replace hormones, if you think about hormones, there's no other endocrinopathy that we use synthetic hormones. When you need to take thyroid, those are bioidentical hormones. Men take bioidentical testosterone. Diabetics take human insulin now. I mean, you may remember when we were residents, we had beef and pork insulin, right?
Hmm.
Someone figured out how to make human insulin in a lab, just like we figured out how to make human estradiol and micronized progesterone.
Hmm.
So I don't know why women don't get the same options. They shouldn't get any synthetic options, honestly.
Yeah. Yeah. Well, you talked about the observational studies where they used bioidentical hormones. They had no increased risk. They seemed extremely safe. Of course, that was an observational study of 80,000, right? Isn't that
80,000,
number?
yeah, over 80,000, yeah.
Which is really profound. So I don't want to I want to hit the hammer again on that. But then saying they're safe, why should women who are in perimenopausal time frame, why should they consider hormone therapy? And I guess we ought to just touch on all the benefits, which
Sure.
that could be a whole, you could talk for hours on that. But as far as cognitive issues, dementia, cardiovascular, bone health, et
Yeah,
cetera.
the best kind of source for women, if they want to look at, is the North American Menopause Society, now called the Menopause Society, is their
Mm,
position statement in 2022. And so they do kind of stack it: skin changes, cognitive changes, mood changes. We know that using estrogen therapy can help midlife depression, which is a big, mental health is an issue. It
mhm,
has been documented that women gain weight at menopause, their basal metabolic rate go down. They won't come out and say that estrogen helps weight because there's so many variables, but there were studies out of the University of Colorado where they had people exercise and it didn't increase their basal metabolic rate or help the fat that was most likely in their, central portion in their abdomen. But when they
mhm,
gave them estradiol, it did help. So the thing about the studies is when they say there are no studies, it's either because there's studies that don't lead to that conclusion or that study hasn't been done. And so
mhm,
when they're ranking, like, we aren't allowed to tell you that taking hormones will help your brain, right? But there's definitely evidence in some of these observational studies, and also what I can say in my practice pattern and what I can say personally. What have I experienced by taking hormone therapy?
mhm,
So when we're talking about one person, that N of one in front of you, we can't say that we're going to prescribe hormones to prevent dementia because that study hasn't been done. But I can tell them about the Women's Alzheimer's Translational Research Study. I can tell them about, other patients' experience. So skin changes, hair changes, energy, mood, weight, libido, cognition, sleep, prevention of bone loss, we can say because that has been proven. We can't say prevention of heart disease, but I see a lot of women whose cholesterol jumps up just at menopause. And
mhm,
so that metabolic picture of increased cholesterol, insulin resistance, carb sensitivity, that seems to be improved by taking hormone therapy at the right dose and the right
mhm,
preparation.
mhm. Yeah, and estrogen is, if I remember right, it is cardioprotective.
Yes. And it's, there is that timing hypothesis that the Mayo Clinic has kind of defined that taking hormone therapy at around the time of menopause is heart protective. So we
Mhm,
have data saying that. But then other studies where they gave hormone therapy to women in their 60s.
mhm.
So that's where there's that kind of recommendation to start it within 10 years of menopause or
Yeah.
before the age of 60, because there's some old data that's probably oral estrogen, oral CEE, or oral progestins that showed an increased cardiac risk. And that's another problem with a lot of the data, is a lot of it is the wrong preparation.
Mhm,
So a lot of that data are the ones that show an increased risk of dementia or heart disease when you start it later.
mhm. Yeah, and that's one of the things with the Women's Health Initiative, wasn't it? The age range was anywhere from 50 to 72. The average
Yeah,
age
the
was like
average age was
60,
like
62.
63.
Yeah. Okay. So, What we know is that starting it within 10 years of the menopause period is close to the, perimenopause area that you need or is the time
Menopause,
to,
yeah.
to begin therapy. What do you say about people who are, let's say they're asymptomatic? I mean, they're going through, their periods are changing and all that kind of stuff, but they're like, I feel fine. What are
Yeah,
your
I mean,
thoughts on that?
I had a friend who was saying, I haven't had a period for 2 years. I don't have any hot flashes. I sleep fine. My energy's fine, but I've
Yeah.
gained weight. And
Yeah.
should I take hormone therapy? She had a family history of diabetes. She had a family history of heart disease, bone osteoporosis. So I think she went to her doctor and had labs, and she's insulin resistant.
Mm-hmm.
So she decided to take the lowest dose. And she said, you know what? I had such terrible joint aches.
Yeah.
I never realized I had this symptom. Yes, joint aches is not an indication to take hormone therapy according to the FDA, but she decided to take it because she was right around the time of menopause and she wanted to get the benefit early start.
Mm-hmm.
And there were symptoms that she didn't realize. So that doesn't mean that everyone should try it. Everyone should have the opportunity to be told of the risks and benefits, and everyone should have, I believe, the opportunity to have the baseline labs.
Mm-hmm.
Just have an assessment to see what they have. I mean, some women don't need estrogen right around the time of menopause, and they make enough. They might even make too much. And so, but I think, if you look at the Endocrine Society guidelines for males, check baseline labs, give testosterone, and monitor. For transgender hormone therapy, check baseline labs, give hormones, monitor. But for women, do not check labs. They don't matter. They're too erratic. Give hormones and don't monitor. So again, part of the problems with the industry.
Well, that's that's a whole different conversation. Women have been on the sidelines of scientific studying and
Sure.
and recommendations, which I got an earful at the Women's health summit. And
You were
I
a
was one of
minority
the
as an
I was one of the
attendee.
6 men there, I think. And
Yeah.
you were so right. So yeah, I agree. They should be given the opportunity. And that's an interesting point. People don't realize a lot of the symptoms they do have because they just get used to them and just that's the way things are. And
And some of them are very subtle because in that time of perimenopause, I mean, by the definition of perimenopause, it can last 10 years now because it's once your cycle goes from like your normal 28-day to 1 week later. And then late perimenopause is once you have a 60-day cycle. So you skip a period. And it's supposed to last 1 to 3 years, but it's lasted 5, 6, 7 years. So I have a lot of patients that are starting perimenopause in their early 40s and, it's lasting 10 to 15 years. So a lot of the symptoms can be pretty subtle.
What's the right age to start checking? Say you're a woman and you're, around 35, 40, and you're just thinking, when's the right age to check?
I mean, that is a great question. And I will say that I am seeing women younger and younger coming in and being more proactive. And I love that, right?
Yeah.
I've checked hormones in teens, 20-year-olds, So when a 20-year-old comes in, obviously their focus is going to be a little different. They may be more interested in their fertility, and so, but I would say definitely in their late 30s is when a lot of women seem to be done with their family and are starting to having hormone changes, or 40s. So I really do. We check hormones at any age. It just depends on what you're trying to look for.
I heard you say before, in a cycling woman, the day to check hormones. This is a question about what date, around day 21, if I remember right. Is that
If
kind
we're
of
trying to look at ovarian reserve and fertility, we'll check between day 3 to 5. But in that time, that's before ovulation and your body doesn't produce progesterone. So it's not the efficient time to assess progesterone. And that's usually the first thing that's abnormal is progesterone. Right. So the best time is mid-luteal, which is around day 19, 20, or 21. Mm-hmm. So it really depends what you're trying to do. And I've recently had patients come in with very specific symptoms, like say day 10. Mm-hmm. Because what happens then is it's right before ovulation. They have a lot of estrogen, no progesterone, and they're very symptomatic with that gap. It's the balance. Mm-hmm. So it really depends on the patient. But mostly we check around mid-luteal, which is day 19, 20, or 21 of a 28-day cycle. Or if someone's trying to get pregnant or is curious about the fertility, we check around day 3.
Yeah. So I have a question about, and this is actually about a patient. She gave me permission to talk about her. She had a total hysterectomy and oophorectomy done and she's pretty young, like late 40s, mid late 40s. And so we were starting her on estrogen, and she was following up with her OB-GYN, but didn't want to start her on progesterone because she doesn't have a uterus. And you've heard this multiple times
Mhm.
before, and it's like, hey, it'll give you cancer, whenever. And the reason that I gave her the option of progesterone, I think it'd be really good for her, is she's extremely stressed out. She's not sleeping well. The estrogen has helped her dramatically with, some of her symptoms she was having out of the gate, and like you said, we did the topical bioidentical biased is what we used on her. But, what are your thoughts on that? How do you, like you just said, the observational studies, it's just not.
Well, let's talk about that.
Yeah.
This is a pet peeve of mine as well. So
Yeah.
in the WHI, when they had the estrogen only arm of CE, of Premarin,
Mm-hmm.
they had 5,000 people. And in that, there was not an increased risk of breast cancer. If
Right.
you actually look at the percentages, and I think I'm pretty close, but don't quote me on the actual number, the percentage of breast cancer in placebo was 0.35%.
Mm-hmm.
And the percentage of breast cancer with the drug was 0.27%.
Yeah, it was lower. Yeah.
Okay, lower, but not even a tenth of a percentage lower,
Yeah.
800ths of a percentage lower,
Yeah.
right?
Yeah.
And so you're hearing, oh, it's lower. There's lower risk in estrogen only. Okay. And so that was a randomized placebo with 5,000 people.
Mm-hmm.
The Nurses Health Study had 122,000 people,
Mm-hmm.
and they saw an increase in breast cancer in estrogen only to the tune of 20% increased risk, not a percentage, 20%. Up to 35%, depending on whether it was 10 to 19 years, longer than 19, with estrogen only. And that was 122,000 women. In the E3 EPIC cohort that we said that was 80,000 women, there was an increased risk of breast cancer in the estrogen only arm as well there.
Mm-hmm.
So there's two studies off the top of my head, and there's another one that Kent Holtorf references in his article,
Mm-hmm.
that unopposed estrogen. Now, if you don't have a study, let's think about the physiology.
Mm-hmm.
Would you ever give estrogen only to someone with a uterus? No, we know that unopposed estrogen increases breast cancer. Our textbook, Leon Spiroff, Reproductive Gynecology, says that the endometrium and the breast cell is similar, and that progesterone prevents breast cell hyperplasia.
Mm-hmm.
We have data from that. We have Chang already did a study where he put estrogen on the breast and then he put progesterone on the breast, and they looked at the histology and they saw that progesterone does the same thing in the breast and the uterus.
Mm-hmm.
So unless you're getting your uterus out and you're also getting your breast removed, you have an estrogen and progesterone receptor in your breast and actually every cell of your body. And we know that because breast cancer patients, what's the first thing they do? They look at the estrogen and progesterone receptors.
Mm-hmm.
You have progesterone receptors in your brain and your bone.
Mm-hmm.
There's more than a woman does than just procreate her uterus, right? There's every cell of the body. So you're giving a stimulatory hormone without the complementary hormone that causes apoptosis. So I believe there could potentially be an increased risk of breast cancer for estrogen only. That's based on the couple studies that I've shown. Now, I could be wrong. Maybe the breast is different than the uterus, but all the other things that progesterone does on your body that helps with sleep, help with mood, estrogen prevents the breakdown of bone, but doesn't build bone. Progesterone, there's some studies that say it builds bone. So I do 100% of the time give progesterone with estrogen for any of my patients, even if they don't have a uterus and even if they don't have breasts too. So
yeah,
that's my opinion. It's not the common opinion,
yeah,
but it's the science and the physiology. I mean, you look at our textbook that speaks to that. It basically says progesterone prevents breast cell hyperplasia.
Mm-hmm.
So that worries me.
Yeah, that it doesn't happen all the time, but I mean, it just
I still
came
think
up.
it happens a fair amount of time.
Yeah,
Because the Menopause Society is giving that recommendation that you don't need. But what you don't need is a progestin, right?
Mm-hmm.
You don't need a progestin if you don't have a uterus.
Right.
And that's where that's coming from, is the increased risk from progestin.
Yeah. And we're talking about micronized progesterone orally, crosses the blood-brain barrier and all that. So yeah, whenever I start giving that, which brings me to the perimenopausal phase, and correct me if I'm wrong, one of the first things I'll see, whether it's testosterone or progesterone, usually progesterone will come down, is one of the things most alarming first. And then when you treat that, the micronized progesterone, it just can make all the difference in a female. And the weight thing you touched on is really important, but we don't have time to even go through that today.
Right. That's another discussion. There's so many hormones that affect weight.
Yeah. So we got the ideal age to kind of consider
Not really. I
checking?
think there's no ideal age. I think anybody that has any of those complaints,
Yeah.
you can have regular periods and still be having issues. I think it never hurts. I mean, of all the women that I've seen, I think there's only been a couple that have come in, wanted their hormones checked, and they've been fine.
Yeah.
There's usually sometimes might be an adrenal hormone or an androgen, like you said, but almost never has someone come in to
Yeah.
me and not had something out of line.
Yeah. Yeah. Absolutely. Another thing that I do want to check on, and I don't have much more time because I want to be respectful of your time, and I'm really just happy you're here, doctors. So estrogen breakdown is kind of important, right?
Yeah.
And we check that in a urine form in most of our patients after they've been on estrogen for some time to kind of just see how they're breaking things down. And I think that's really important. So anybody listening who sees anybody who's on hormone therapy, it's a good idea to do that. But so what are some of your recommendations on that? Why do you recommend that? And kind of go through that briefly if you can.
Well, again, it always used to surprise me that when I was doing gynecology, how some women could have their ovaries removed and be fine and never take hormones. And some women would go through menopause with their ovaries and be desperate,
Yeah.
for hormones. So why the change until I understood about estrogen metabolism? It's kind of like if I told all my patients to drink 2 liters of water and one patient is running a marathon in 80 degrees, that 2 liters of water is probably not going to be enough. And they might get dehydration if they follow my recommendation versus another patient that's on dialysis. If they drink 2 liters of water, they might have heart failure. So does that mean water is dangerous and we should never drink water because it could cause heart failure or it could cause dehydration? No, it just means that the person and how their body handles water varies. And that's what your recommendation depends on. Well, it's the same thing with estrogen. Our enzymes that break down estrogen in our liver are genetically coded. They can be altered. They can also be induced or inhibited by other drugs, other hormones, foods. So everybody has a different rate of metabolism. Just like when you drive to the hospital, if you're driving at 8 a.m. after 4 inches of snow, it might take you a lot longer than if you're driving at 1 p.m. in the summer. Your commute is going to take different depending on external things. It could also depend on if there's construction. So that's like the highway of estrogen out of your body. The first 2 steps of the liver, the third's in the gut. And so there's a lot of variation in how that is. So if you're somebody who doesn't clear estrogen, you can be susceptible to estrogen pathology. So I believe, and this is not another uncommon opinion, I mean, most of us in the functional and integrative space agree, but our traditional menopause, providers, NAMS doesn't talk at all about estrogen detoxification or even checking hormones for that matter. So I do believe it's important to see how people are handling hormones themselves. I think, to not only check the either blood levels, saliva levels, if it's appropriate, but urine levels at least one time to know how patients are metabolizing hormones.
Yeah. Well, cool. What other things? We only have a few more minutes, so I just want to make sure we cover anything. What other things are important that you think of?
I mean, there's only a few conditions where I would be hesitant to prescribe hormone therapy to patients. I mean, if you have active breast cancer and you're undergoing treatment, we really don't want to give you estrogen. We really don't give you any hormones until you're done with your treatment. But I have given hormone therapy to breast cancer survivors because we're seeing women younger and younger. If you have breast cancer treatment at 40 and now you are 55 and you have no recurrence and you're going through menopause, you may be able to take hormone therapy, but you need to find a provider. If you look at the Menopause Society, it doesn't say you should never give hormone therapy. If you look at the guidelines, the menopause position statement, it says for severe vasomotor symptoms that are unrelenting with non-hormonal therapy, you may consider hormone therapy with the discussion of the oncologist for the breast cancer patient. It never says don't ever give hormones to somebody who has a first-degree relative of breast cancer. It says for the breast cancer patient with unrelenting vasomotor symptoms, you could consider hormone therapy. So that's the important thing too. 1 degree, we always calculate breast cancer risk, but 1 first-degree relative doesn't mean you can't take hormone therapy. It does mean you need to be careful. The other thing I get asked about a lot is blood clots, and if you have a thrombophilia. So again, we don't give oral estrogen. I've safely given transdermal estrogen to people with a prior history of a PE, pulmonary embolism, blood clot in their lungs, or a blood clotting disease with monitoring, though,
Hmm.
not everybody, right? We don't just say, here's your hormone, come back in a year.
Hmm.
So those are two conditions. The only other thing that I think is melanoma. So that is a hormone estrogen sensitive cancer. So if you have metastatic melanoma, may not be right for you. And stage 4 high grade uterine cancer. Those are the ones that are sensitive to estrogen. But again, I've given hormone therapy to people who have a history of ovarian cancer, cervical cancer, of course, uterine cancer that's not stage 4 high grade,
Yeah.
people with blood clots, people with breast cancer. But you have to really have someone who knows how to wade through the pros and cons.
Right. So you've given it to people who have a history of breast cancer in the distant
Yes.
past that's treated.
Yes,
Okay.
I have. That is a very individual risk assessment.
Yeah.
That is a discussion with the patient on what they're comfortable with.
And that is probably somebody who should see a certified menopause practitioner, such as yourself, or
Someone who definitely is
yeah,
familiar with the pros and cons. I
yeah,
mean, again, the certified menopause practitioner is still somewhat traditional. They do at
yeah,
least,
true.
they're at least not as hesitant as the traditional practitioner
Hmm.
to prescribe.
Yeah. Which brings me to a few other things. As far as testing, following up on these people or women, mammograms, ultrasounds, what's kind of your protocol on that you
Since I'm not doing mainstream GYN, I'm not usually the person recommending that, but
okay.
mammograms are what we have. There's a new imaging modality that's ultrasonic that Dr. Jennifer Simmons. Oh, actually, I have her book right here.
Yeah.
Smart Woman's Guide to Breast Cancer.
Yeah.
She's great. I don't know if you've had her on your podcast, but she's a breast cancer surgeon
Yeah.
who now is doing integrative approach. So she's involved in the something that's an ultrasound imaging. So there's no radiation, and it's much more accurate than mammograms. So that's another option.
Show us that book one more time.
It's probably backwards, right? The Smart Woman's Guide to Breast Cancer.
Yeah. Okay.
Yeah.
Cool.
Yeah.
Cool.
Yeah, that just came out, and I, she's a colleague of mine, and so she used to do breast cancer surgery on patients, and then now she's helping patients prevent it, and then also go through their treatment. So a lot of great stuff in there.
Okay, cool. Well, thank you for that. Is there, in closing, I guess, is there anything else that you wish everybody knew? I mean, if it was an alert on everybody's phone or something like that for every woman, what do you
I
think
just
is
wish they could get with a provider that would talk to them about the risks and benefits and alternatives. I mean, we kind of covered a lot today.
Yeah.
I got lots of free stuff on YouTube. We have a free newsletter you can sign up for that we're kind of going over a lot of as the studies as they come out. Those are other options, but just, know that it's not an all or nothing thing.
You do have a good website. I signed up for your newsletter, and
Oh, you did? Okay.
yeah, I did.
We're ramping it up this year.
And then, you provide a lot of good information just on, dietary stuff that's really easy to follow. So I would recommend people checking out your stuff. And you do put a lot of good information out there that I think is quality. So thanks for being you. And I appreciate what you do.
Well, thanks for doing the podcast. I know it's a lot of work, and it's another option for people to get the right information.
Yeah. Well, hey, enjoyed the day. Thanks for making time. I really appreciate you, Dr. Scott.
All right. Take care.
All right.
Bye-bye.